Hello, I'm Dr.Jazeer and welcome to this fourth video about the INICET recall questions. So earlier we had done almost 8 to 10 questions each in previous 3 episodes, and now this is the fourth one. So let us continue with the dermatological question discussion for INICET. So let's go to the first question now. The disease that is associated with the occurrence of blistering and peeling of over more than 30% of the body surface area is usually caused by. The options are drugs, viral infections, autoimmunity and fungal infection. So what is the diagnosis in this case? The question says there is a blistering and peeling of the body, but more than 30% of the body surface area is involved. So whenever we say about a body surface area involvement, please remember, if less than 10% of the body surface area is involved with massive blistering and bullous kind of lesions with peeling of the skin with mucosal involvement as well. So in such cases we categorize them as Stevens-Johnson syndrome. Whereas if more than 30% of the body surface area is involved, we call it as a condition which is a dermatological emergency called as toxic epidermal necrolysis, TEN. So according to this question, the most likely diagnosis is toxic epidermal necrolysis, where more than 30% of the body surface area is involved. So what is the most likely cause? So we all know that TEN usually is seen when there is a side effect to a certain drug. Okay, so this is seen as a drug eruption. So the answer here would be drugs, that is option A. Okay, so what do you find in the histopathology of toxic epidermolysis? So in the histopathology of TEN, you will be able to see necrotic keratinocytes. So you will be able to see necrotic keratinocytes. Also please remember, pseudo-Nikolsky sign is also seen in toxic epidermal necrolysis. So now let's go to the next question. A patient presents with multiple nodulocystic lesions on the face. Which among the following is a drug of choice in this condition? So you can see this image where the patient is presenting to you with multiple nodulocystic lesions. So nodulocystic acne is considered to be the severe form of acne, because you have comedonal acne, you have papillopustular acne, and the severe form is going to be nodulocystic acne. So in such cases, isotretinoin, tetracycline, erythromycin or steroids, which is the drug of choice? The answer is oral retinoids, which is called as isotretinoin. So isotretinoin is the first line of choice when you have a severe kind of an acne called as nodulocystic acne, as in acne conglobata or in acne fulminans. Okay, so now let's go to the next question. A 5-year-old boy had painful sores in the mouth with a rash on the hands and fever. What is the causative agent? So the options are HIV virus, HHV virus, Coxsackie virus and pox virus. So what you see in this image, a child, 5-year-old boy is having fever. Along with fever, there is some sores in the mouth as well as the hands are also involved. So hand is involved, mouth is involved, fever. So what comes to your mind? Hand, foot, mouth disease, isn't it? So hand, foot, mouth disease is again a viral infection, but in the options all virus is again given. So what is the most common causative organism in HFMD? So correct answer is HFMD can be caused by either Coxsackie virus or enterovirus EV71, isn't it? So among these options, enterovirus is not given. So the answer is Coxsackie virus, which is again the most common causative of hand, foot, mouth disease. Now let's go to the next question. Which cell is not present in the layer that is marked? So you can see that a layer that is being marked here, that is which is a layer? You can see the entire layers of the epidermis. So in this layers of the epidermis, the layer that is being marked is a lowermost layer. So what is the name of the lowermost layer of the epidermis? The name is stratum basale. So in stratum basale, do you remember what are the cells that is seen in the stratum basale? So all of us know that 90% of the cells of the epidermis is keratinocyte. So keratinocyte is definitely seen. So the other cell that is seen in the stratum basale is the melanocyte. So melanocyte is also seen. The other cell that is seen in the stratum basale is Merkel cells. Okay, the slow adapting touch receptors. So Merkel cells are also seen. So what is not seen in the stratum basale is the Langerhans cell. So where do you see Langerhans cells? Langerhans cells is seen in the stratum spinosum. So the correct answer here would be D, that is Langerhans cells. So now let's go to the next question. Topical steroids are most effective in. So this was an AIIMS 2019 question. So among the options are rosacea, bullous lesions due to HSV, eczematous dermatitis and dermal atrophy. Okay, so dermal atrophy is easy for us to rule out because the atrophy is usually a side effect of using a steroid cream, isn't it? So among all these options, the right one is going to be, when do you use steroids? Steroids are used to bring down an inflammatory process, to bring down any kind of an allergy, isn't it? So out of all these things, which is an allergic pathology that is given here, that is eczematous dermatitis. So here the right answer would be C, that is eczematous dermatitis. So now let's go to the next question. So in this question, in patch test, after how many hours is a patch removed to examine the site of reaction? So the options are 24 hours, 72 hours, 96 hours and 48 hours. So we know that patch test is a test which we do for the diagnosis of allergic contact dermatitis. So in allergic contact dermatitis, with patch test we are actually testing for a type 4 hypersensitivity, which is also called as a delayed type of hypersensitivity. So type 4 hypersensitivity, delayed hypersensitivity. So once you apply the patch, you usually remove it at 48 hours. So the right answer here would be 48 hours. So, but if the question was something different, so at how many hours is the patch test best read? If the question was something like that, the answer would have been 96 hours. But in this questions, it is usually at how many hours is the patch test read? It is read after 48 hours. Okay, so that is all about this question. So let's go to the next one. A patient was treated with steroids for psoriasis. On stopping the treatment, the patient developed fever, malaise and lesion as shown in this image. So what is the most probable diagnosis? The options are staphylococcal infection, pustular psoriasis, acute generalized exanthematous pustulosis and subcorneal pustulosis. So what do we understand from this question? It is the same question which we have discussed in one of the previous episodes of INICET recall. Okay, the similar one has been tested again. So it is a psoriasis patient. In psoriasis, we should never treat the patient with an oral steroid, because if we treat a patient with an oral steroid, what is expected? You are expecting a generalized pustular psoriasis or the von Zombush reaction. So what is the answer here? You can see a lake of pus. Okay, you can see multiple pustules are seen in an erythematous base. So this is called as von Zombush reaction or generalized pustular psoriasis. So the correct answer is option B, pustular psoriasis. So let us see the last question today, that is, all of the following have maculopapular rash except. So options are measles, dengue fever, rubella and herpes zoster. So in which of the following do we not see a maculopapular rash? So we know that measles has an exanthematous maculopapular rash. In dengue fever also we are expecting a skin lesion as such, exanthematous rash is expected. In rubella also the same is expected. But what is the type of rash that you expect in a herpes zoster? In shingles, you expect grouped vesicles on an erythematous base on a dermatomal distribution. So you are expecting vesicular rash in the case of a herpes zoster. So the right answer here would be herpes zoster or shingles, where we do not expect a maculopapular rash. So I hope this discussion has been useful. I'll again come up with few more questions that has been asked in INICET in the next video. So till then, happy learning. Thank you so much.